Okay, we've got it now. Okay. Well, that allowed me to waste a little bit of time. So I'm recording because some people are out, and this chapter is so important for nursing that I don't want to have you miss anything. We have an exam coming up next week, so I don't want anyone to miss anything. So reminder about the quiz and lab today and tomorrow. So we come on time, start by taking the quiz. If you come in late, I have to ask why you're late, and then you have to do a makeup because we got to stay on schedule. So anyway, like I said in class, I don't need this little thing here, do I? No. Get out of the way. It's going to be 10 questions on, sorry, we're here. 10 questions on the blood glucose lab. That includes the vocab. That includes the negative feedback of blood glucose regulation that we talked about. And that includes the class data. Do not memorize numbers, but trends. What happened to blood glucose over time for people that drank the full sugar beverage versus the water, okay? And then 5 questions on the boldface vocab in the cell metabolism handout. Click that here. So make sure you look at this with enough time to look over those boldface terms. And I think it's just the front page that has it, okay? All right, so that was the reminder for that. This thing. Any questions about that? So just like the lecture quiz, it can be multiple choice, matching, fill in the blank, and a very, very like short answer. All right. So now I don't need that. Any other questions about anything? Okay, just a reminder that Wednesdays, I don't have it on the online syllabus because I just don't. But Wednesdays after this class, I have office hours. If those don't work and you have any questions about exam material, like I've had a student coming in for questions and help already multiple times because we have our exam coming up next Friday. I hope you're studying. I mean, I hope you're like through studying the metabolism chapter, chapter 2, part 1, and are now working on chapter 2, part 2, which we finished, cell transport. And then I hope, you know, like no later than next week, you're starting chapter 4, part 1, getting this down, what we're doing right now. All right. Don't wait till the last minute. That is not the way to do it. That'll never work. Unless you have a photographic memory, which most of us don't have. Okay. We good? Okay. So let's get started. We had covered, basically I talked about acetylcholine signaling, which is what you're going to need to know for the upcoming exam. All right. And that includes, you know, what acetylcholine controls voluntary skeletal muscle activity. And the receptor for acetylcholine is called cholinergic, but I gave you 2 types. This is me doing some review. I gave you nicotinic and muscarinic. So stop and think on this Monday morning. Which cholinergic receptor do you have on your skeletal muscles? Is it the nicotinic or is it the muscarinic kind? Nicotinic, because you think nicotine's in a cigarette and you need voluntary muscle movement to pick up the cigarette or the vape or whatever, put it to your mouth. So nicotinic cholinergic. Now, if I'm talking about the cholinergic receptor on your heart to slow your heart rate down during rest and digest activities, is that going to be a nicotinic or a muscarinic? Muscarinic, because you remember muscarinic, you have no choice. It's autonomic. Good. Awesome. Okay. If you did that without having to look at notes, I know you're studying or you paid attention when I went over it, and that's good. All right. And then I talked about what the body does during rest and digest, pantomimed it up front, what makes sense. Rest and digest, you're resting, heart rate goes down, bronchioles constrict down a little bit, your GI tract, all that increases. All right. And it's a good time to urinate and defecate, good time to go potty. Okay. All right. And then to kind of talk about when acetylcholine signaling goes wrong, I talked about things that inhibit acetylcholinesterase. Back up. What's acetylcholinesterase? It's an enzyme, it's an ASE. What does it do? Breaks down acetylcholine in the synapse. We need acetylcholinesterase, or else we're going to have problems, like death is coming problems, okay? If you're exposed to an agent that, if you're otherwise healthy and have no other problems, and you're exposed to an organophosphate pesticide, like the dog I was talking about, okay? Or you're exposed to sarin gas, herb gas, or something like that, all right? That agent is acetylcholinesterase inhibitor. It stops acetylcholinesterase from breaking down acetylcholine. As a result, you have too much acetylcholine in all of your synapses. In your skeletal muscle synapses, your skeletal muscles are being stimulated, and you can see these, all right? Your GI tract is going to be on hyperdrive because acetylcholine promotes all GI tract activity. So you might vomit, emesis. You might have diarrhea, things going through the large intestine too fast. You will have salivation, maybe frothing at the mouth, because salivation, those glands are part of the digestive system. And then all these other things I talked about, bronchoconstriction, drop in your heart rate. And then I talked about the treatment for the cholinergic syndrome. Now, what I forgot to ask last time, because I knew it was a lot, and that's why I'm recapping this morning. So 2-PAM is the cure. It restores the enzyme. Doesn't happen quickly. It might take a few hours. So to save your patient from all of the muscarinic cholinergic effects, the drop in heart rate, the bronchoconstriction, all the spastic GI tract stuff, the urination, all that, all right? You give them atropine to block the muscarinic cholinergic receptors on all those places and stop that. And then Valium, known as benzodiazepine, to stimulate more GABA-like activity. GABA makes your skeletal muscles relax. You probably know Valium is a muscle relaxant. It is. And it would stop the seizures to bring the body temperature down. So is Valium a GABA agonist or an antagonist? It's an agonist. Yes. Okay. So let me turn this down. See what my pen color is today. It's an agonist because it causes more of its activity. Good. Threw a lot of stuff at you last week, so it was worth the time to recap. All right, so we'll move on. All right, now toxins could be from bacteria, could be something else that affect acetylcholine signaling. Again, only the ones I think that you might encounter as nurses. Tetanus. You all have to be tetanus vaccinated to be a student here. And then to work on a job, you have to be tetanus vaccinated. It has to be updated about every 10 years, right? I have a small farm. I've got to keep my animals tetanus vaccinated. They're goats and they get into all kinds of mischief. All right. So if you had microbiology with Dr. Lyles or Dr. Pryor, I know you've covered tetanus. Okay. It's a bacterium, Clostridium tetani. And it's not the bacteria that are the problem. It's the toxins that they spill into your bloodstream. Those toxins mess with the acetylcholine signaling. Let me move this. I don't like wants to be center of the screen, but we'll slide it over there. All right. It's an acetylcholine agonist. It promotes more acetylcholine-like activity. All right. Here's a classic textbook image, which you might have seen in microbiology. I don't know why that likes to be there. Come back. Go someplace. Well, that's not that bad. This person is in full body muscle tetany, like their muscles have locked up. Have you ever had like a Charlie horse where you stretch and then that tendon that connects to that toe muscle just locks in place? Have you ever had that? Is it really painful? Yeah. Okay. Imagine this. Imagine all your muscles rigid like that. That's what full-blown tetanus would do. All right. That's why we have the vaccine for it. So the bacteria can be found on rusty metal. If you get a deep puncture wound. And it's a small hole that seals over. It provides the perfect anaerobic environment for that bacteria to thrive, pump out those toxins. And the toxins cause, I like to call it go back then. Come on, there we go. Hyper, which means excess. And tonia, muscle tone. That's the muscle locking up. All right. Hyper always means excess, and then whatever follows has a meaning too. Or spastic paralysis. I don't like that because paralysis implies the muscles are limp, and that's not the case. So I like hypertonia. Okay, one of the first signs of tetanus is trismus, and this is a link. You can actually go to Wikipedia definition. Lockjaw. It goes after the mastication muscles first. I don't know why, but that's a first sign. Okay. And then it progresses to the rest of the body, all right, eventually going after the respiratory muscles. Tetanus, more recently, we found it to be a glycine and GABA blocker. Oh, so we got a two-pronged attack on your skeletal muscles, causing them to lock up. Promotes too much acetylcholine activity, and it blocks the neurotransmitter that we just talked about, that normally relaxes your muscles. It blocks that. So now the muscles are being stimulated to contract and they're being prevented from relaxing. All right. Don't worry about this. It's too much right now. Okay. So you can prevent with your tetanus vaccine every 10 years, make sure it's current. Okay. And then if someone has gone past their 10 years or they don't know when they were last boosted for tetanus and they have a deep functional wound, you can give them their vaccination. And then to really protect them, you give them a shot of tetanus antitoxin. Does anyone know what an antitoxin? Well, it's an antitoxin, right? Do you know exactly what it is and how it's working as preventing the toxin from having its effect? Confidence, if you know, go ahead and say it. It's okay. Now go ahead. Don't doubt yourself. Don't doubt yourself. You know. Maybe. What do you think? What's the way you think? I want you guys to feel comfortable to talk. All right. I was watching Dr. Middleton and her nursing students. She was showing how to put colostomy bag. It was fake, and they were wearing around the lab, and they were laughing and they were talking. I want you guys to feel relaxed and able to talk. Yes, an antibody protein. What it is, it's an injection of antibodies against the tetanus toxin, and those antibodies will bind to that toxin and inactivate it. It's the same thing with snake anti-venom. You get bit by a venomous snake, you get snake antitoxin for that species. It's a protein-based antibody that seeks out that toxin in your body, binds to it, and inactivates it. So it's good to know how antitoxins work because they're life-saving. All right. Okay. Now, so that was an acetylcholine agonist. Too much acetylcholine, hypertonia. Now we're going to look at hypotonia, where the muscles are too relaxed. Okay, now we're talking almost like paralysis. So did I have it? I did. Let me double check and make sure that this link is working. It is. All right. So if you're looking at the PowerPoint online, you click the links and then you can come. And this talks about botulism too, which is what we're going to talk about next. All right. Both bacteria, both Clostridium, but different species. Okay. Well, you're not going to need to know all this. I'm going to explain it more simply. Okay. So let's back out of that. Okay. And back to my PowerPoint, which is where? There we go. 3 things that produce toxins that can cause hypotonia. All right. And there's a clinical app online for this. So clinical presentation of someone with less acetylcholine, not enough. These are going to be acetylcholine blockers and they're going to be equally bad. So botulism. Okay. You can get that from improperly canned food. There's always all kinds of food recalls, E. coli contamination, who knows what. Every now and then you're going to see a botulism recall on products. So it's also an anaerobic loving bacteria. And so it will thrive in a canned product that wasn't properly canned and Clostridium got in. Usually adults will just have a bunch of diarrhea and be really, really, really sick. But young children and old people or anyone who's immunocompromised, they're going to be in trouble. Okay. So botulism is produced with the toxins produced by Clostridium botulinum. And it prevents acetylcholine from leaving the presynaptic neuron. Acetylcholine doesn't get released from those little vesicles, just stays there. So there's no acetylcholine in the synapse. So with skeletal muscles, you will see hypotonia. All right. I think Dr. Pryor calls it floppy baby syndrome. All right. Yeah. Because they're just, okay. So again, now flaccid paralysis, I like hypo, which is low, and tonia is muscle tone. Now, since we know acetylcholine also does muscarinic effects, could it affect your heart? Could it affect your bronchioles? Could it affect your GI tract? Yes. Okay. All right. But we're more worried about the loss of muscle tone, especially with respiratory muscles. That's the danger there. The GI stuff, all that's not going to kill you. But in a young baby or something like that, the hypotonia could be a real difficult problem. Okay. So doesn't leave the neuron. Here's some other things. And, oh, is there another way you can think of that someone could get botulism that has nothing to do with canned food? No, that has too much air exposure, unless the soda was sucked into a anaerobic container. What is that stuff that people go to get injections to Botox, to get wrinkles to go away on their face and everything like that. Botox is supposed to be an inactivated form of botulism toxin, which does what it does, relaxes muscles. So you go get those injections around your, they call crow's lines around your eyes and the smile lines around your mouth or wherever. It's going to relax those muscles so you don't see those lines. And now, if you get FDA approved Botox from a licensed physician, PA, nurse practitioner, you're probably fine because it's been through inspections. But if you buy that crap off the internet, not knowing where it came from, and go to these Botox parties, don't do that. Okay. You could get inferior Botox that is not really inactivated. And yes, it does happen. I don't know the percentages, but it happens. I'm aware of it. Paralytic shellfish poisoning. And I have enough here. You can look at the online, but this is a sign that you'll see at beaches sometimes. Certain times of the year, they say, do not eat the fish, do not harvest the shellfish. Listen to those signs. We have a wonderful coast, all right? And people go there and yes, they harvest, oysters and I don't know, maybe clams. I don't know if we have, but that's the main thing. I know a lot of people harvest the oysters, which are shellfish. Now, the danger is certain times of the year, especially warm times or when there's been a lot of runoff from the land. Where is it? Red tide. Okay. Red tide is red from an algae. And these algae produce the toxin, saxitoxin. All right. And what happens is shellfish feed by filtering that water. And what happens is they concentrate that saxitoxin in their flesh, which is what we eat. And so you would be consuming a higher concentration of what's in the water because they're filter feeders. And so here's how this causes hypotonia, blocks acetylcholine nicotinic ion channels. That's found on your skeletal muscles. Now they're not going to get since it's blocking those ion channels, you can't get the sodium entry into the skeletal muscles. They can't contract. And now they're hypotonia. All right. So again, hypotonia and saxitoxin is an acetylcholine blocker by blocking the ion channel. It's not doing anything to the acetylcholine levels. It's just preventing it from having its effect. Now, so that's a real thing. All right. People are going to come in because they don't listen to the damn sign and they go in there, harvest and eat the shellfish. And then they come in, I don't know why my muscles won't work. I can't stand up. You find a patient history. All right. And then there's things you can give them. And I'll get to that in a second. And then the last one, I don't think you'd see at Myrtle Beach. I don't know how high end their sushi restaurants might be, but it's possible. It's within the realm of possibility. But pufferfish poisoning. Fugu pufferfish, the fish that can inflate themselves to defend themselves, right? They have tetrodotoxin and they have these glands. So first of all, they're kind of spiky fish and they puff up to be scary. But if something eats them and consumes that gland, they're going to die. The chefs that prepare the fugu fish have to be licensed because if they don't excise that gland that has the toxin, you're going to kill the people in your restaurant. All right. But anyway, it does the same thing that the algae do in paralytic shellfish poisoning, blocks the nicotinic cholinergic ion channels. Your skeletal muscles can't be stimulated. And so again, causes the hypotonia. I can't circle because it won't let me. All right. So if you go to a sushi restaurant and if they happen to offer the fugu pufferfish, unless you have a death wish or want to put your life in the hands of a chef that you haven't even seen in the restaurant, you might want to avoid that one. Okay. Okay. All right. Now I've presented to you. Oh, acetylcholinesterase inhibitors. Bad. Dumbbells. Cholinergic syndrome. Bad. 2-PAM. Get atropine. Get Valium. Stat. All right. Yes, that's true. Okay. Because you have too much acetylcholine in the synapse. And that's the problem. What happens if you don't have enough acetylcholine? What happens if you're suffering from paralytic shellfish poisoning? All right. There's other things they can give, but let's say you have a disorder. I have a good one. Here's a disorder where an autoimmune disorder that antibodies are produced in your body that attack your own acetylcholine receptors on your cells and destroys them. And once those receptors are gone, neural systems don't have a good way of repairing themselves. So once those acetylcholine receptors are gone, the nicotinic receptors on your skeletal muscles, the muscarinic receptors on your heart, or body functions. All right. They're not coming back. So those muscles aren't getting stimulated enough with acetylcholine that's there. There's just fewer receptors. What do you do to improve muscle function? It usually presents first with an eye droop, and then some problems with smiling, goes after the facial nerve stuff first, and then it progresses to your limbs. You might start dropping things. You might start having a little hard time ambulating, moving around, and left untreated, eventually it's going to go inward to your respiratory muscles. You're not going to be able to breathe very well because those are nicotinic cholinergic receptors. So here is the myasthenia gravis. Is that disorder? It's a disorder where your immune system is going haywire and is producing antibodies, autoimmune destruction of acetylcholine receptors. Okay. So I added this in red. It's not on the PowerPoint that you have because I updated it on the 12th of September. So if you just downloaded that, then you've got it correct if it's in red here. If it's not, you can add this stuff. Because I wanted to say it's not just skeletal muscle weakness. It's also going to go after your swallowing muscles and your respiratory muscles. My stepdad died of this, like in July, 4th of July. He was a veteran. How tragic, right? I'm always going to remember 4th of July. My stepdad died. He had oculopharyngeal, like a myasthenia gravis. And his respiratory muscles gave out on him. And he'd been suffering with it for years, okay? But anyway, muscle weakness, swallowing problems. Your pharyngeal muscles are the ones that fold your epiglottis over your opening to your trachea when you swallow. If those muscles become sluggish because they've lost receptors and they're delayed, when you swallow, you could aspirate some of this stuff into your airway and you have aspiration pneumonia and things like that. I know someone else that died of that, not family, but I know that's how he died. And then eventually left untreated, it goes after your respiratory muscles and people go into respiratory crisis. They have to go on a ventilator. And then once you're on a ventilator, we know this from COVID, once you get put on a forced air ventilation system and you have a problem like this or COVID, it's very unlikely you're coming off of it. All right. So your immune system, auto is self, and immune is your immune system is going after self, destroying the receptors. Here's an antibody attacking a receptor. Here's another one. So the thing is, once a person's diagnosed with an autoimmune disorder like this, I asked you this question before. What would be a good treatment for someone with an autoimmune disorder where their immune system is immunosuppressants? Okay. That's one thing. Slow the immune system down. So you slow down the destruction of those receptors and they can exist for a longer period of time. Okay. So myasthenia gravis interrupts acetylcholine signaling, not by affecting acetylcholine, but by affecting its receptors. All right. Kind of like shellfish poisoning and fugu pufferfish poisoning. They mess with the ion channels. Okay. Alzheimer's. We've all heard of Alzheimer's and we've learned a lot. I talked about how acetylcholine is always a stimulatory thing in the brain. It makes the brain metabolically active. In the bright areas on this PET scan, the yellow, the red, all that shows metabolically active areas of the brain. And these happen to be the brain's cortexes. Here's the insula. Here's the thalamus, I think. Okay. So loss of acetylcholine producing neurons in the brain is associated with Alzheimer's. So here's a normal brain with all those active areas. Here's a brain of someone who's suffering from Alzheimer's. Notice a lot of these cortexes on the outer side they've gone dark. All right. And they're not coming back once those neurons are gone. We don't have the technology or understanding yet of how to get the nervous tissue to repair itself. Maybe one day, but not right now. Okay. It's also thought to be due to excess production of another neurotransmitter we haven't gotten to. I mentioned it on that table of all the neurotransmitters. Glutamate is also stimulatory. So I'll say ACH is stimulatory. Glutamate is stimulatory in the CNS, central nervous system. So if you lose acetylcholine, you're losing that stimulation. Now, this is interesting. So you need acetylcholine, and low levels make the brain go dark. Glutamate is also stimulatory, but when you have excess glutamate, it's actually toxic. Right? So glutamate toxicity or high glutamate also is associated with these problems. So the more we understand about how neurotransmitters are messing with a disorder, the more likely we are to be able to come up with a treatment. All right. Now, what happens if you have someone who has Alzheimer's and they don't have enough acetylcholine? Or someone who has myasthenia gravis who They had the acetylcholine, but the receptors for it have been lost. You can treat them with an agent that causes a buildup of acetylcholine in the synapse. What have I been covering? That can act as an acetylcholine agonist, an acetylcholinesterase inhibitor. They're not going to expose these people to organophosphate pesticides, nor are they going to expose them to sarin gas. We have pharmacologically prepared acetylcholinesterase inhibitor that is given to people with low acetylcholine signaling. Did I just blow your mind? I gave you too much acetylcholine, bad cholinergic syndrome. But too low acetylcholine is also a problem. And then you'd want to increase it. You see how I did that? That's pharmacology. Okay. Too much, too little is a problem. Okay. So you have this blocked out, so you'd be able to write it in. So question, what do you give a patient with low acetylcholine, like Alzheimer's or myasthenia gravis, or, something like that, or have a loss of acetylcholine receptors? This is where the stupid, but you have it if you have your, okay. Loss of acetylcholine receptors to improve their functioning and help with their symptoms, because their skeletal muscles are going to not be functioning very well. An acetylcholinesterase inhibitor. All right. So you're not going to have to memorize these drugs. Do not memorize. I'm just giving you, hey, is this relevant to nursing? Yes. Okay. Let me back up a little bit. So Alzheimer's, they have, galantamine, rivastigmine, a lot of igmines, all right, are acetylcholinesterase inhibitors. For myasthenia gravis, neostigmine, pyridostigmine, they are acetylcholinesterase inhibitors, but they're pharmacological drug. And so you can alter doses and all that stuff. All right. And it's been studied, FDA approved, and then marketed. Okay. So that will prevent acetylcholine from breaking down in the synapses with all those muscles and glands, so that their skeletal muscle has extra acetylcholine for the few remaining receptors that are there. Now, do you think these drugs, like any drugs, come with side effects? Yes, if you take Tylenol, it's got side effects. Read the bottle, okay? Anything you take has side effects. So you are trying to improve skeletal muscle function by providing more acetylcholine in the synapse with those muscles because they've lost receptors. Do you think it's just going to increase acetylcholine in the receptors with skeletal muscles? Do you think it would increase acetylcholine in the receptor on the heart muscle? Yes. You got to watch these patients for a drop in heart rate, bradycardia. Do you think it increases acetylcholine in the smooth muscle of your bronchioles, leading to some bronchoconstriction? Yes. If a patient has myasthenia gravis and asthma, that's going to be a tricky one because you're going to provide extra acetylcholine for their skeletal muscles to work, but it might come with some bronchoconstriction. That might be a problem for them. Welcome to pharmacology. There are drugs that you treat a primary symptom that have side effects that mess with another thing that they have going on. And then you'll start reading about contraindications. This drug is good for a person, except if they have this problem. All right. Just getting your brain thinking like that. All right. Okay. So these drugs improve muscle function and these disorders like myasthenia gravis or Alzheimer's, but the side effects from high acetylcholine, drop in your heart rate, everything GI could go on hyperdrive. These people could experience nausea, their stomach is kind of hyperdrive. You might experience diarrhea, things like that, and bronchoconstriction. If you're asthmatic, that might be a problem. All right. So what drug could you give to keep the heart rate up, slow down the GI system, block the bronchoconstriction, all that stuff? What's a drug that I gave you as treatment for cholinergic syndrome that will stop those muscarinic acetylcholine functions? It begins with an A, atropine. Okay. So if someone is you could give this to someone with myasthenia gravis and maybe they don't have any of the dumbbells symptoms. Maybe they're fine. But another patient might say, oh God, I had such bad diarrhea. Oh, I just couldn't function. I could barely leave the house. All right. Okay. We probably need to prescribe you some atropine along with your acetylcholinesterase inhibitor so you don't have those side effects. Huh? You starting to feel it now? This is what everyday nursing is going to be like. All right. But you'll be trained and you'll have experience and it becomes second nature. Now you're like, holy shit, Dr. Barbeau, this is a lot. It is a lot, but that's what you're looking at doing for a career. And a lot of this, you're going to see these are myasthenia gravis is common. Okay. And so being familiar with acetylcholine signaling, and when it's messed up with the disorder, the drugs that treat the disorder, understanding how they work. And then when someone comes in from their main prescription with side effects from a mnemonic dumbbells that you've learned, you know this drug will help treat those. Physiology, nursing, yeah. Okay, it's a lot. It's enough to make your brain spin. But, and I'm not going to do it here, but I found a really good YouTube video of someone explaining acetylcholine signaling and myasthenia gravis and the drugs used to diagnose and treat. All right. It helps reinforce what I've taught you. When you look at information multiple times over and over again and in different formats, like I presented you stuff in table format and figure format, in written out format, I do that to repeat myself, not to drive you nuts, but the more I go over it, the more likely you're going to retain it. And so study that way. All right. It's the only way I know how to memorize this stuff. All right, we good to move on? Okay, so yeah, acetylcholine signaling, you need to know that stuff for the upcoming exam. All right, and I've taken my time because I want to make sure that you follow along. And I've asked you questions, and want feedback and you guys to talk. I want you thinking. This is not one of those classes you just get by studying your notes and flashcards and Quizlets and all. You got to stop and think about the material a little bit. Okay. Now we're moving on. This is not on the exam, all right? Not on the exam. Thank God, right? Not on exam. Catecholamines, and I know they call them this in nursing form. Catecholamines include dopamine, norepinephrine. Norepinephrine is in your central nervous system. Epinephrine is in your peripheral nervous system. They do the same thing. They're stimulatory. They're fight, flight. Okay. Do not memorize this. It's just to show you. They're all made from an amino acid known as tyrosine. So here we have tyrosine. All right. That becomes L-dopa. That becomes, I think that says epinephrine. Let me move it. No, it becomes dopamine first. See, even I don't have it memorized. Becomes dopamine because L-dopa is a precursor. Then from dopamine, you make norepinephrine, and then that gets converted to epinephrine. Pathways, don't memorize that. But they're all made from the same thing. Dopamine, we're going to talk about a lot. You're going to see. So I asked you this before. Are you aware of the opioid painkiller crisis in medicine? These painkillers, opioid-based, Percocet, what was I prescribed for my mastectomy? It'll come to me. But anyway, it was opioid based, and I was afraid to death of taking it because I knew of the addiction that could come with that. So I just took a high dose of ibuprofen. I stayed away from me. I can't think of it, but probably in 5 minutes it'll come to me. But anyway, they're prescribed it because of pain, and it does take away the pain. But here's what happens when you do something, eat something that produces a pleasurable or reduces pain. It causes a release of dopamine in your brain. And that dopamine is that feel-good neurotransmitter that reinforces you to do, again, what caused either the pleasure or the release from pain. And the more dopamine that's released every time you do it, the stronger the psychological addiction is. That's dopamine, all right? Dopamine plays a role in psychological addictions, and that's what makes a lot of addictions hard to break. There's physical addiction, they have withdrawal, but the psychological one, that's tougher. Serotonin is also a monoamine neurotransmitter made from a different amino acid, tryptophan, which you find in turkey or warm milk. Right. All right, so serotonin, I've mentioned this, few receptors in the brain and a lot of them in the gut where we still don't know what it's doing. All these are considered monoamine neurotransmitters. So, oh, this isn't working. So, removal of these neurotransmitters after they've done the job. Reuptake. Remember, I had diffusion, enzyme breakdown, glial cell removal, and then reuptake. So reuptake works best with, serotonin. I'm waiting for my pen to wake up. SSRIs. Remember, we talked about it, wrote it on the board. Okay. Do I need to define it again? Go back to your notes. What Give it to me. Selective serotonin reuptake inhibitor. Citalopram, Lexapro, Prozac, Zoloft, I think. Which came first? I think Prozac came before Zoloft. But anyway, they work as SSRIs. Okay. So I know this is blocking it. This is just because I'm recording. Here's another thing that can increase these monoamine neurotransmitters. Enzyme breakdown by monoamine oxidase. It was in an earlier slide. Okay. MAO stands for monoamine and then O oxidase. Breaks down dopamine, norepinephrine, epinephrine, and some serotonin. Okay. I'm going someplace with this. You've heard of SSRIs. Have you heard of MAO-Is? MAO-Is. The I stands for inhibitor, just like acetylcholinesterase inhibitor. And guess what it does? It inhibits this enzyme from breaking down dopamine, norepinephrine, epinephrine, and serotonin. It's a pharmacological drug, can also be used to treat depression or dopamine signaling disorders or other things. So very common. So did you get a chance to got it? Okay. So if you have low levels of dopamine, and that can happen in certain disorders, some of you know a lot coming in here. Anyone know of a low dopamine disorder that's associated with muscle tremors and they have a hard time? Parkinson's, perfect. All right. Parkinson's is low dopamine in the brain. Okay. So there's lots of different ways of approaching it. You can give them L-Dopa, which is the precursor to dopamine. You can also give them something like an MAO-I, which inhibits the breakdown of things like dopamine, serotonin, norepinephrine, and epinephrine. All right. But there's two types, at least that I know of. There's probably more by now. There's monoamine oxidase inhibitor A, and then there's another one. So when I think of I came up with this. If you can come up with something better, please do. But when I think of A, I know it can increase norepinephrine. I know it can increase, of course, epinephrine. Okay. It can also increase serotonin a little bit. So when I think of A, I think of agitation because epinephrine is fight-flight neurotransmitter. That's adrenaline. Epinephrine's adrenaline. And so if you're flooded with norepinephrine or epinephrine, you're flooded with adrenaline, and you're going to be a little agitated because that's fight-flight. Now, serotonin, low serotonin can be associated with depression, things like that. But remember I said 90% of the receptors are located in the gut. So I think appetite, because that's a GI thing. So I think A, appetite, serotonin, there's 90% of the receptors are in the gut. It's a bit of a stretch, but it helps me tell the two different MAO-Is apart. All right. If you can come up with something better, please do. So there's also MAO-I class B or type B. And so that's an agonist to dopamine. It prevents dopamine breaking down. So when I think of MAO-I-B, I think dope beat. Okay. Dope is for dopamine. And you'll find out later that dopamine is involved in addiction, but it's also involved in fine motor control. So if you want to, right, make a beat. I'm terrible at that. I'd never be a drummer. But I think beat, fine motor control, like you're drumming something. And I think dope, B, MAO-I-B, right? Now let me ask you another question. If someone has low serotonin, why don't you just give them an SSRI? Confidence. Not quite. That's fine. You're the bravest one. You actually spoke up. Good for you. Okay. Are we all carbon copies of each other? Our physiology is the same as mine, the same as yours. Yours is yours, right? What happens if I had depression? I had low serotonin, and I was given SSRIs. That was the first thing they prescribed, but it didn't work. You come back in. Someone comes back in as a recheck. Look at what the medications they're on. Say, oh, how are the SSRIs treating you? This should be a part of your patient history. You know, because you're going to be talking to them first. It's really not working. I'm just feeling just horrible. It's not working for me. Write it down. Let the doc know. Because if that's not working, try MAO-I class A. And that's another way to increase serotonin, and that might work for that person. All right. That's why we have multiple drugs, because not everyone's going to respond to the drug the same way. You can also mess with dosages and things like that.
Quick question.
Yeah.
So like, what is too much serotonin?
That is an issue. That's a side effect of SSRIs or MAO-Is. And some people, a little dab will do you, like citalopram, 10 milligrams, the lowest dose, right? And if that works for someone, great. If not, they might double that, triple that, quadruple that. And it'll increase their serotonin. But they might have a side effect of now too much serotonin. Have you ever heard of serotonin cascade or serotonin syndrome? People can have hallucinations, they can have muscle tremors or seizures. Yeah, that can come with I actually witnessed someone have this there at my house. And after she recovered, she says, okay, this is going to pass. It's serotonin syndrome. And I talked to her about it and I was educated about it. All right. So yeah, that can be a side effect. That's a little past what I was going to go for today, but I wanted to introduce things that can increase these other neurotransmitters. And there's two classes, and here's a way to remember them. But yes, too much serotonin from these drugs can cause a problem. So that's why when people come in and you're doing a recheck, how you doing on that medication we prescribed for you? Because if they say, you know, I was feeling fine, less depression and things like that. I had this weird thing happen. I swear to God, I was hallucinating. I was not vivid dreaming. I was wide awake and I had this weird hallucination. That can be a side effect of the drug. The serotonin, high serotonin can cause that. All right. And then you need to know, you might need to tweak that. The doctor needs to tweak that dosage, but you got to report to them the patient history of that. All right. So again, I'm not teaching you anything that you don't need to know for nursing. All right. But very good question about excess serotonin. Neurotransmitters are kept within a normal range, and each person's normal range is going to be a little different. Now you do EMT, right? Have you ever seen anything like this in someone? No. Okay. I don't know how common it is, but I know my friend had it. So, all right, let's continue on with serotonin. So the reason I have the picture of someone who's doing LSD and having hallucinations, and there's lots of chemical messages in the brain that can cause hallucinations, not just serotonin. But anyway, 10% of receptors are in the brain. So if you don't have enough serotonin in your brain, you could have memory problems, mood problems, emotional upset, and hallucinations. Or, you know, well, if you have too much serotonin, you can have some of those. And what it's doing in the gut, 90% of the receptors, we still don't know. Maybe you choose not to do nursing, maybe go to grad school, become a researcher, research this, find it out, become the cover of Science, and, you know, develop a new drug that helps someone. Low serotonin associated with depression, anxiety, I'll add that. And obesity, that I did not bring up before, because serotonin is playing a role in appetite in the GI tract, although we don't know exactly how. Okay, so now, I don't think I have it here, do I? No. What two drugs could you give someone with low serotonin to increase that serotonin? SSRI. Yep. Yeah, you have to think about that, right? MAO-I. And you remembered A standard for either anxiousness, anxiety, or appetite. And 90% of the receptors for serotonin are in the gut. All right, good. Good. And this, I just went over you. Why would you have multiple drugs to treat the same problem? Not everyone's going to respond to a drug. I say responds to, when I say drugs, I'm talking about the pharmacological one, the same way. And the same thing goes with the illicit drugs too. Not everyone responds the same way. And someone could take a hit of meth and be fine and jacked up for a day, and another person it could kill them. All right. So don't be experimenting now. All right. Same thing with people using the attention deficit disorder drugs and using it to stay awake. These things don't act the same way in everyone. And some people might have an underlying condition they're not even aware about that drug hits. All right. So don't experiment unless you've got a condition, because it's always going to be side effects. So serotonin and depression, serotonin being released from a neuron to another neuron, okay, into the synapse. And if you have low serotonin, it is associated with depression. So there's really nothing on this slide except, oh, look, SSRIs, all right, prevent the reuptake of the serotonin by that neuron. So more remains in the synapse. All right, dopamine. Dopamine is very interesting. I don't know if you learned the different neurons in the midbrain, but you probably learned where the midbrain was in anatomy. Okay, it's just under basically the hypothalamus. So you find the midbrain right there. And then it has the corpora quadrigemina, you probably learned that. But the midbrain, small little brain structure, does a lot of important things, okay? It has neurons that produce dopamine. So it's produced by the substantia nigra neurons of the midbrain, dopamine. So dopamine, I'm giving you two functions. It has many functions, but I'll give you two. Fine motor control, okay? Like we can contract our arms. I'm contracting my biceps, but that looks pretty ragged, doesn't it? To do the fine motor control, you need dopamine, okay? So dopamine, fine motor control is called the nigrostantial dopamine system. That's just what it's called, all right? Fine motor control. I mean, just like what I did. If you have low dopamine, insufficient, it's associated with Parkinson's disease. And I'll let you read that clinical app online. But to treat Parkinson's, what drug could you treat someone with Parkinson's that we just covered that would basically increase dopamine in the synapses by preventing its enzymatic breakdown? MAO-I. So you could treat, and TX means treatment. You could try an MAO-I class B for the dope beat, and that might increase dopamine. See how I get you thinking? And you've probably never heard of these before, right? And I did my little, right? Now all of a sudden, oh, MAO-I type B, of course, right? Be creative when you're studying and you'll never mess this stuff up. Okay. And then there's L-DOPA and all these other things. Too much dopamine is associated with schizophrenia. So I'm not as familiar with schizophrenia. I knew someone who had it. They think voices are talking to them, things like that. They're forgetful, but really they live in a little alternate reality. And some people are high functioning schizophrenics and some need to stay in assisted living because they're a danger to themselves and others. But you might want to treat them with a dopamine blocker. All right. Now, also not shown here, dopamine is released in the brain when you do something that feels good. Okay? You're going to encounter as nurses addiction. And we're just going to end by talking about this because it's a real problem. You got to spot it. There's going to be people who have drug-seeking behavior and they come in and they were prescribed in the past for a broken arm, Percocet or something like that. And their arm has been healed for a year now. And they're saying, oh, I'm still having some aches. I don't know, every time it rains, I get aches. Can I get some more of that Percocet? No, try some ibuprofen. Because when you do something that's pleasurable, like taking pain medications, in some people, you get a huge dopamine release and it reinforces doing that again. Some people are addicted to food. Some people are addicted to shopping, gambling, you name it, dopamine release. And so you have to break that dopamine release pathway to break psychological addictions. So you got to give them some tough love. All right. So we will pick up with this on Wednesday. All right.